Hi, this is Dr. Charlotte Derr, and I am the Fellowship Director for the University of South Florida's Advanced Emergency Medicine Ultrasound Fellowship. I'm going to speak to you today about cardiac pathology on POCUS, a guide to diagnosing critical conditions. In this lecture, I will not be reviewing how to obtain the basic echo windows, nor will I be going into detail about echocardiographic anatomy. If you are a novice POCUS user, I hope you will watch our Introduction to Cardiac POCUS lecture by Dr. Martinez prior to viewing this lecture. I have no relevant financial disclosures. So our objectives today will be to recognize the sonographic signs of cardiac tamponade, such as right atrial systolic and right ventricular diastolic collapse. You will also learn to evaluate left ventricular systolic function using both qualitative and quantitative estimations of ejection fraction. You'll also learn to identify signs of acute pulmonary embolism, such as right ventricular hypokinesis, chamber enlargement, septal flattening, and McConnell sign. We will not have time today to cover aortic aneurysms, aortic dissection, regional wall motion abnormalities, valvular emergencies, or diastology. So let's begin with talking about effusion and what an effusion looks like on ultrasound. And you can see here we have an anechoic or black fluid collection between the visceral and parietal layers of the pericardium. So this is what a pericardial effusion looks like on ultrasound. Now, fluid is typically anechoic or black on ultrasound, but in cases of more complex effusions, like those with fibrin, you might see echogenic areas within the fluid. And clotted blood will also appear echogenic as it becomes more dense. So it's important to think about differentiating a pericardial effusion from a pleural effusion, and one of the best ways to do that is in the peristernal long axis view. Here we have a peristernal long axis view. Here's the apex of the heart, the left ventricle, and you can see surrounding that left ventricle is a fluid collection. Is it pericardial or is it pleural? Using our peristernal long axis window, the key is to look at the descending aorta. In the example on the left, we have a pericardial effusion, and we can differentiate that from a pleural effusion because it crosses the midline anterior to the descending aorta. In the example on the right, we have a pleural effusion, and we know that it's a pleural effusion because it's seen posterior lateral to the descending aorta. So when in doubt, you can always check another echo window. And if you think that you have a pleural effusion, don't forget to look at the lung at the PLAPS point to confirm. So here's that example. Here is that fluid collection wrapping around the left ventricle. Here's the thoracic aorta. It doesn't appear to come around the ventricle in the short axis view. In a 4-chamber window, I do not see it at the apex. Moving to a subxiphoid view here, again, I no longer see that fluid collection. I'm suspicious it is in the lung. So I'm going to a PLAPS window here. And indeed, here's the diaphragm. Here is a large pleural fluid collection. You can see the tip of the lung here. So this ended up being a large pleural effusion. But you can see at the beginning of the clip, it can be a little difficult to differentiate whether it's around the heart or in the lung. So please consider using that peristernal long axis window and confirming in other echo windows. And then if you believe it's in the lung, go ahead and go down to that PLAPS point. So don't forget to check the lungs. Now, with the pericardial effusion, size does not necessarily correlate with the presence of tamponade. So you can have rapid development of a small effusion that can then lead to tamponade, and you can also have a very slow and gradual development of a large effusion that doesn't necessarily cause tamponade. So look at this small effusion wrapping around the apex of the heart. It's small, but in this case, it ended up needing to go to the operating room because it later caused tamponade. Now, some people will ask, well, how do I estimate the size? If you freeze an image and then measure the width of the fluid collection in that pericardial sac, If it's less than 1 centimeter in size, it's estimated to have less than 300 mLs of fluid. If it's 1 to 2 centimeters in size, it's estimated to have 400 to 600 mLs of fluid. And a large effusion is considered to be greater than 2 centimeters in size, which equates usually to greater than 700 mLs of fluid. So now that you've identified that pericardial effusion, how do you know if tamponade is present? So the first thing to look at is systolic collapse of the right atrium. This is done nicely in your four-chamber or your subxiphoid views. This is considered a very early sign of tamponade. And it's sensitive but not specific for tamponade. It's not unusual to see transient buckling of the right atrium in other types of patients without tamponade, but collapse of that right atrium, which persists more than a third of the cardiac cycle, is considered more specific for tamponade. So, practically speaking, absence of any diastolic collapse of the right atrium would argue against tamponade, while if the RA is collapsed most of the time, this supports the diagnosis of tamponade. The next thing to look at is what's going on with the right ventricle. We're looking for diastolic collapse of the right ventricle, and this is very specific, about 75 to 90%. And the severity of tamponade is correlated with how long that chamber looks to be collapsed. It's easier to review this in slow motion on your ultrasound machine or using a more objective measurement of M mode in your peristernal long axis, which we will review in just a moment. Let's just quickly jump into looking for evidence of collapse using the eyeball method before we go to M mode. So visually looking at what's going on with the right side of the heart, we can see there is bowing in of the right atrium. We can see that the RV wall is collapsing, nearly obliterating the cavity of the right ventricle in this patient with a large pericardial effusion. And as I mentioned before, this can be very helpful to review in slow-mo. Now let's talk about using M mode for more objective measurement of looking for RV collapse. So when you use your M mode cursor and you drop it down through the mitral valve leaflet tips, the first thing the sound wave is going to encounter is the RV wall. So this is the movement of the RV wall over time, and you can see it's quite flat with very little undulation. The next thing the sound encounters is the RV cavity, which is represented here. The septum, and this is the movement of the interventricular septum over time. The movement of the anterior leaflet of the mitral valve. You've got the left ventricular free wall at the bottom, followed by the pericardium. But I want you to focus on here is the fact that there's very little undulation in the movement of the RV wall. And using M mode is relatively easy. Touch M mode on the right, align your M mode cursor over the anterior leaflets of the mitral valve, touch M mode again, and you will get this tracing over time, which you will then freeze, and it will look like this. So in your normal patient, in this upper left example, there's very little fluctuation in the RV wall. But when we look at the patient with a large effusion, you can see that the RV wall is bowing in during diastole. And I know it's this diastolic phase because the mitral valve leaflet tips have opened towards the septum. This is the early diastolic filling, what we call the E wave, the atrial kick, what we call the A wave, and then it's closed. So during diastole, I look upwards with my eye to see what the RV is doing, and it is bowing inwards towards the RV cavity. So that is evidence of tamponade. We can also look to see what the IVC is doing. Let's look at the IVC during expiration and then inspiration and see if there is any respirophasic variation. With tamponade, the IVC remains plethoric and fairly non-collapsible, and this is 95% sensitive for tamponade, but not very specific. Remember, there are other conditions that cause the dilated IVCs, such as volume overload, right ventricular dysfunction, severe tricuspid regurgitation, patients that are on positive pressure mechanical ventilation. So looking at the IVC in this example, we can see there's very little change in the size of the IVC during inspiration and expiration in this patient that has a pericardial effusion. So this patient did have tamponade. Now, something I want to briefly mention as you obtain more advanced echocardiographic skills is the use of pulse wave Doppler in placing a pulse wave Doppler sample gate over either the mitral valve or tricuspid valve to look for changes in inflow velocities. When you do this in a patient with tamponade, you're going to see variation in the height of those inflow velocities. When you see a greater than 25% change in those heights when sampling over the mitral valve, or greater than 30 to 40% change in heights when sampling over the tricuspid valve, this is indicative of cardiac tamponade. This is the pulsus paradoxus visual on ultrasound. Now remember, during normal inspiration, negative intrathoracic pressure facilitates venous return to the right side of the heart. But in tamponade, the increased pressure on the heart leads to impaired filling of the ventricles, especially the right ventricle, which leads to a reduced stroke volume and therefore decreased flow velocities across the valves during inspiration. So that's why we see those changes. Here's an example of a case from our emergency department where we're sampling over the mitral valve inflow region. And you can see with the E wave and the A wave, E wave and A wave, that during inspiration, the heights, velocities of those waves are much smaller than during expiration. So in this example, there was definitely a difference between E to E and A to A that was greater than a 25% change. This patient had tamponade. So let's quickly review, starting with visually. Looking at this patient, is there tamponade? Well, I see bowing in of the right atrium. I see collapse of the RV wall. This patient has tamponade. In this example, what is happening to the RV wall? Is it bowing in? Well, in this example, it can be difficult to tell, so I'm going to request another window and look at the peristernal short. In this example, I do see that RA wall bowing in. Maybe there is a little bit of collapse of the RV. Moving to another window in this patient, this apical four-chamber view, now I think I am seeing more collapse of that RV wall, still lots of collapse of the RA wall. And going into the subxiphoid, now I feel I have confirmation that there is definitely bowing in during diastole of the RV free wall. This patient has tamponade. And another example, a smaller effusion, but is there collapse of the RV wall during diastole? Now in this case, I believe I see a little bit of bowing in during diastole, but I'd like a more objective measurement using M mode. And during the diastolic phase, when the valve is open, I look up to see what is the RV wall doing, and it is bowing in. There is fluctuation, movement of that RV wall and bowing in during the diastolic phase, consistent with tamponade. In this example, again, I'm concerned that I see RV bowing. I want a more objective measurement. So I use M mode, and I see quite a bit of fluctuation, even more than that last example, this bowing in of the RV wall during the diastolic phase of the cardiac cycle, which is consistent with tamponade. Right now, we're going to shift gears and go into assessment of global left ventricular function. To begin with, we're going to start with a qualitative assessment of LV function, and that's simply looking at the LV to determine, does the mitral valve anterior leaflet tip come and touch the septum? If it comes very close and touches the septum, then this is consistent with good left ventricular systolic function. The other thing that we can ask in looking at the left ventricle walls, are they pulling in evenly? And when they do so, do we see some change in the volume in the LV cavity? In this example, the LV anterior leaflet does not come up close to the septum, and I'm seeing very poor movement of the LV walls during systole. So this is a patient that has reduced systolic function. You can also assess this in the peristernal short axis view. I like to use a cursor or maybe just place a finger on my ultrasound image when I'm reviewing a clip, and I ask myself, are the LV walls pulling in evenly? Now, perhaps they are pulling in evenly and they're coming so close together that they're considered to be hyperdynamic. Now, that's not the case in this patient, but that is something that you may be able to appreciate. You might also be able to appreciate some wall motion abnormalities. You can see in this example, the inferior walls are pulling in and thickening during the cardiac cycle, while up towards the septum, this is not the case. There's very little thickening or pulling in towards the cursor in this patient. So we're not going to go into depth with wall motion abnormalities, but that's something you might also be appreciating on your ultrasound. And if you have any questions, think about slowing down the video. You can do this on all of your point of care ultrasound machines and slow it down maybe in half time. And it makes these wall motion abnormalities and the ability to appreciate this decreased squeeze even more substantial. So as far as that qualitative assessment, we can see anything from a normal ejection fraction to mildly reduced, a moderately reduced ejection fraction. Note the movement of this mitral valve leaflet tip does not come very close to the septum. To that is severely reduced with very little motion of the anterior leaflet tip towards the septum and very little squeeze inwards of the left ventricular walls. The opposite would be a hyperdynamic LV where the walls are coming together and nearly touching each other. So using a qualitative assessment, what do you think of the function of this left ventricle? That's correct. There's very little movement inwards of the ventricular walls, and this anterior mitral valve leaflet does not come up near the septum. So we will consider that this patient has severely reduced systolic function. You won't be surprised when I tell you the patient presented with difficulty in breathing and that they had B lines on their lung ultrasound, as well as this appearance on the IVC. What do you think of the IVC? It looks plethoric. There is minimal change in the diameter of the IVC during inspiration and expiration. This combined with the IVC, these findings suggest volume overload. Now, what about quantitative measurements of ejection fraction? We're going to review E-point septal separation, also called EPSS, fractional shortening, mitral valve annular plane systolic excursion, referred to as MAPSI, and the Simpson method. Let's begin with E-point septal separation. This measurement is performed using M mode in a parasternal long axis view. I really like this measurement because it's easy to learn and can be performed very quick in a clinical setting. So using M mode, bring the cursor over the anterior leaflet tips of the mitral valve, touch M again, and you will obtain the tracing of structures over time. And then you will freeze that measurement and it will look like this. You'll have an E wave representing early diastolic filling, an A wave representing the atrial kick. And you're measuring the distance between the peak of the E wave and the septum. The larger the EPSS distance, the worse the ejection fraction. Remember, this needs to be a parasternal long axis view, and I want to emphasize that you need a horizontally oriented left ventricle. We'll go over how to correct that in just a moment if you have more of a longitudinally oriented left ventricle. But remember, it needs to be more horizontal for that measurement to be accurate. The M mode cursor is placed over the tip of that mitral valve leaflet, and you're measuring the distance from the E wave to the septum with a normal measurement considered to be less than 7 to 8 millimeters. And for a measurement greater than 18 millimeters, this is considered to be a severely reduced ejection fraction. Now, I think this is interesting. This study looked at 124 patients who had cardiac MRI done, and they measured the EPSS and estimated the ejection fraction based on that measurement. Using a regression analysis, the MRI of the LV ejection fraction could be estimated from the following equation, where the EF was estimated using 78 minus 2.6 times the EPSS in millimeters. Don't worry about memorizing that equation. They found that this had a strong regression coefficient. And looking at their numbers, you can see that if you have an EPS measurement of 20 millimeters and you look up and look at this line and bring your eyes over to this axis, you'll see that correlates with about a 25% EF. Now, simplifying this further, we can use this chart where we can consider an EPSS less than 7 to be normal 7.4 to 8.9 low normal, 9 to 13.9 mild systolic dysfunction, 14 to 17.1 moderate systolic dysfunction, and you can see an EPSS greater than 17.1 correlates to severe systolic dysfunction with an estimated EF less than 30%. Now, here is a little bit more of a simplified version of that formula where the ejection fraction is estimated using 75.5 minus 2.5 times your EPSS measurement, and that measurement needs to be in millimeters. So in this example, we have an EPSS that's been measured and it's 0.6 centimeters. Remember, that's 6 millimeters if you're going to use the equation. And a normal EPSS measurement is less than 7 to 8 millimeters. So this patient has a normal EF. And let's look at another case. So visually, this looks to be reduced using our EPSS measurement in M mode. From the tip of the E wave to the septum, we see we have a distance of 12.9 millimeters or 1.29 centimeters. And remembering our study that we just looked at, if we use 12.9 millimeters, that puts this patient into the mild systolic dysfunction category. Now, remember, I mentioned how you want a horizontal plane. Look at this bottom example where the M mode line is coming pretty much perpendicular to the septum. And this plane is what we want, this horizontal lie, versus the above example, which is more of a vertical slant to the ventricle, meaning when the M mode line comes down and intersects the septum, it's no longer perpendicular. And the way that you can try to correct this is by moving the probe more superiorly or cephalad, usually up 1 or 2 rib spaces. And that'll take it from this axis to more of a horizontal lie. Now, EPSS has other limitations. It does not account for regional wall motion abnormalities. So if you have a poorly thickening, poorly moving septum, that can cause you to have a falsely elevated measurement in that area. You can have a falsely elevated EPSS with mitral stenosis due to the stiffness of the valve. You can also have an elevated measurement with mitral regurgitation. Think about that backward flow of blood from the left ventricle to the left atrium during systole. It prevents the mitral valve from closing properly. And this can affect movement of the anterior leaflet, making it less mobile and limiting its ability to reach the septum. Aortic insufficiency can also cause a falsely elevated EPSS. With this condition, blood leaks back, and this increases LV volume and dilates the chamber, pushing the septum farther away from the mitral valve. You can have falsely decreased EPSS measurements. Think about a hyperdynamic left ventricle and how vigorously it's contracting. This exaggerates motion of the mitral valve, lowering the EPSS distance. And with hypertrophic cardiomyopathy, the septum is thick, so the distance to the mitral valve is reduced during diastole, leading to a lower measurement, even if the LV function is compromised. Now I'm going to briefly mention fractional shortening for estimating EF. This is less commonly performed than the EPS measurement when we're talking about point-of-care ultrasound, but I think it's important to know. The fractional shortening is measured in the peristernal long axis using M mode, and it's looking at the percent change in the LV diameters. Using an equation where you take the end diastolic diameter and subtract it by the end systolic diameter, dividing that number by end diastolic diameter times 100, it gives you a percent change. Values greater than 25% are considered normal. They equate to normal systolic function, a normal EF. Values that are less than 14%, then you're likely to have an EF that's less than 30%. There are some pitfalls here as well. Wall motion abnormalities can lead to overestimation or underestimation of the fractional shortening measurement. Let's take a look at this illustration, make it a little bit larger. Using M mode, we're going to bring the cursor down just below the level of the leaflet tips, and you will have the movement of the septum and LV free wall over time. We place our first caliper at end diastole, the area where the LV cavity is the widest, and our second caliper at end systole. And then we measure that diameter where the LV cavity is the narrowest. At this point, the ultrasound will do the remainder of the calculations for you and give you a fractional shortening percentage. Here's an example on the left of a normal fractional shortening percentage. And you can appreciate this visually by just taking a look at the size and change of the end diastolic diameter compared to the end systolic diameter of the LV cavity, and see that these two are very different diameters in size, versus the illustration on the right where there is very little change between end diastole size and end systole size. So we're not surprised to see a fractional shortening percentage of only 7%, well below the 25% normal cutoff. Let's talk about MAPC for estimating ejection fraction. The mitral annular plane systolic excursion. This is measured using your apical 4-chamber view. When you're in that view, you'll take your M mode line and you will drop it down over the lateral mitral valve annulus. You'll hit M mode and get a movement over time of that lateral annulus, and you'll want to measure the peak to the valley, and that measurement is your MAPC. It's a simple and fast measurement, but it is angle dependent. You need to make sure you have a nice straight up and down apical 4-chamber view. This measurement is affected by rhythm and rate. For example, in atrial fibrillation, the contraction of the left ventricle is inconsistent, which affects the movement of the mitral valve annulus. This plus variable filling will lead to fluctuating MAPC measurements. At higher heart rates, diastolic filling time is shortened, which can reduce the extent of mitral annular excursion. The LV might not fully relax between contractions, leading to lower MAPC values. At lower heart rates, longer filling times lead to potentially higher measurements. So keep that in mind as you're measuring MAPC. Our normal value for MAPC, women should be greater than 11 millimeters and men should be greater than 13 millimeters. Let's look at this MAPC example. Here we have our M mode sampling through the lateral annulus. And in our tracing over time, we see nice sinusoidal up and down movement of that annulus. We measure our first caliper placed at the peak, and we'll place our second caliper down at the trough, and we're measuring that vertical distance. In this case, the vertical distance is well above the normal threshold for women and men. This is a normal MAPC. Now, you might be thinking, well, what is the gold standard for measuring ejection fraction? And that's the Simpson method, the method of discs. It calculates ejection fraction from the entire volume of the left ventricle during systole and diastole. And this method involves tracing the endocardial border of the LV in two planes, usually the apical 4-chamber and apical 2-chamber views. And this is done at end systole and end diastole. The computer takes that LV cavity and divides it into a series of stacked discs, and the volume of each disc is then calculated. By measuring volumes at the end of diastole and systole, this measurement is considered very accurate as it accounts for variations in the LV shape. But this measurement can also be difficult, time-consuming, and is operator-dependent. And you have to be very carefully when tracing the endocardium to not include things like the papillary muscles. So while it is our gold standard, you can imagine that you're going to have a patient that has really clear windows to be able to properly trace the endocardial border at end systole and end diastole. Here's an apical 4-chamber view at end diastole, and they're very carefully tracing the endocardial border. And then these horizontal lines generated by the machine are calculating the volume using this system of discs at each level. You then cine loop and go to end systole and trace the endocardial border again. This is then repeated in the apical 2-chamber view at end diastole and end systole. The computer will then calculate your ejection fraction. So the Simpson method is the one touted as best by cardiology, but clinically it takes quite a bit of time to perform correctly. We are now going to jump to the right ventricle and talk about how to assess right ventricular function. And this begins with a visual 2D assessment of the right ventricle. I like to do this in the apical forechamber and the subcostal views because this allows me a side-to-side comparison of the LV diameter compared to the RV diameter. As you can see in this example, the RV diameter should be about 2/3 the size of the LV diameter. The RV should not extend past the apex of the left ventricle, and the apex should consist of the LV only. The other thing that I can look at is get a better look at the RV free wall and ask myself, is it moving and is the cavity getting smaller during systole? Now let's visually assess this example. Here the RV is greater in width than the LV, and it takes up the majority of the apex of this heart. We can also assess the right ventricle in the peristernal short axis view. The septum should not be flat or D-shaped. It should be rounded, consistent with a nice round left ventricle, and the RV should be crescent shaped. So what is abnormal and what does that look like? In an abnormal right ventricle, we have more of a circular shape to the RV, and the septum becomes more flat. Now, as you watch this example, I want you to look at the motion back and forth of the septum. As pressure in the RV increases, the RV becomes more circular. And with a large PE, the clot obstructs the pulmonary arteries, increasing the resistance to blood flow from the right ventricle. This results in elevated RV pressures as the right heart struggles to pump blood into the lungs. And as that RV pressure rises, it begins to exceed LV pressure during diastole and sometimes even during systole. This pressure difference causes the interventricular septum to flatten or bow abnormally towards the left ventricle, particularly during systole when RV contraction is at its peak. And therefore, paradoxical septal motion is often seen. Let's take a look. Notice we have a very flat septum and a little bit of movement, and it looks like the RV is pushing that septum in to the left ventricle during the cardiac cycle. Remember that under normal conditions, the septum moves towards the left ventricle in systole and back toward the right ventricle during diastole. However, in cases of elevated RV pressure, the septum moves towards the RV during systole instead, which is considered paradoxical because this movement opposes the normal physiology. The LV in turn is compressed, and this can be seen as abnormal movement of the septum. This paradoxical septum motion also causes the left ventricle to take on a D-shaped appearance, and I believe you can see that really nicely in this example. It's no longer circular. The septum is more flat, moving inward, and the LV is now more D-shaped. And this is referred to as septal flattening or a D sign. The other view that you can review the right ventricle in, other than apical 4, peristernal short, or subxi, is that peristernal long axis view. Remember, you can use the rule of thirds, where the diameter of the left atrium should be the same size as the aortic root, which should be the same size as the width of the right ventricle. Let's now take a look in the peristernal long axis window. What do you think of the width of the right ventricle as compared to the left atrial region and the aortic root? It's much larger. This RV is gigantic. In this patient on the short axis, we no longer have that small crescent shape of the RV. It's more rounded, it's big, and it's starting to flatten the septal region of the left ventricle. When evaluating the RV function, we can also look for McConnell sign. McConnell sign involves continued contraction of the RV apex, while there is little movement noted of the RV free wall. Generally speaking, you might have some basal RV sparing where there's some up and down motion of the tricuspid valve annulus in this area, but relative akinesis of the RV free wall. We often see this in cases of acute RV strain, and it's very specific, 97% for pulmonary embolism. I like to say it looks as if the apex of the RV, it's almost like a little trampoline with a little guy jumping up and down, pushing down that apex of the right ventricle. You can also measure the right ventricle. This is not something I do frequently, but if you were to measure the right ventricle, you want to measure the base diameter and mid-level diameter. Normal measurements of the base should be less than 41 millimeters, and normal mid-level diameters should be less than 35 millimeters. You can also measure the diameter of the right ventricle in the peristernal long axis, where you would expect a normal diameter of the right ventricle to be less than 35 millimeters, and these measurements are performed at end diastole. When evaluating the right ventricle, you also want to measure the thickness of the RV free wall. The best place to do this is in the subxiphoid view, and that RV free wall is measured at end diastole. Be sure to exclude the papillary muscles and the trabeculae network in that measurement, and it's really helpful to zoom in. A normal measurement is less than 5 millimeters. In a subacute process, I would expect it to be 5 to 10, but in a long-term process, like with pulmonary hypertension, where there's chronic right heart strain, I would expect a measurement greater than 10 millimeters. So this is the area that we're measuring. You'll see the right ventricular free wall will be up adjacent to the border of the liver, and we're measuring the thickness, making sure not to include any of the valvular apparatus in our measurement. Can you spot where you would measure the RV free wall in this patient? We've got a little bit of the liver in view. Here's the RV free wall, and you would want to measure this RV free wall in end diastole when the volume of the RV is at its widest. Now here's a more difficult example where, because of the brightness associated with the RV free wall, it's a little bit more difficult to see and differentiate it from the liver. But we might as well give you real life examples because this is what you might encounter. So when you freeze this at end diastole, make sure that you zoom in. You can see without zoom, it's relatively difficult to see where to place the calipers, but this is the RV free wall, which is up adjacent next to the liver. And we want to make sure our caliper does not extend into the RV cavity, which is represented by this anechoic region. So let's talk about TAPC and right ventricular dysfunction. Right ventricular dysfunction occurs in 30 to 70% of patients with pulmonary embolism, and we know that based on the literature that it's associated with increased mortality, longer hospital stays, and the development of pulmonary hypertension. The tricuspid annular plane systolic excursion, or TAPC, is a measurement of RV dysfunction, and it's known to have prognostic significance. A great thing about TAPC is it's probably the least user-dependent measurement of right ventricular dysfunction. But keep in mind, TAPC is not very specific for pulmonary embolism. Its specificity is only about 70%, because we can have reduced TAPC also seen with right heart failure, secondary to COPD, pulmonary hypertension, right-sided MI, and even when left heart failure causes right heart failure. So how do you perform TAPC? TAPC is performed in the apical four-chamber view. You'll take your M-mode cursor and you'll put that spike over the tricuspid annulus over on this lateral side of the right ventricle. And you'll tap M-mode again and get a recording of the movement of these structures over time. You're going to measure peak to valley using those ultrasound machine calipers, and a normal measurement is considered to be greater than 17 millimeters. So in this example, we have a nice normal TAPC at the top of the screen. Notice the very nice sinusoidal up and down motion of the tricuspid valve annulus versus the abnormal TAPC below, where it's a relatively flat wave. In placing your calipers at the peak and the trough, in the above example, you have a TAPC of 28.4 millimeters, well above the 17 threshold, so this is normal, versus the TAPC below, where you have a very small measurement of only 6.3 millimeters, definitely abnormal and a marker of right ventricular dysfunction. Here's another clinical example. Notice very nice vertical height on this patient who has a normal TAPC versus an abnormal TAPC in a patient with pulmonary embolism and right ventricular dysfunction, where there is very little vertical up and down movement of the tricuspid annulus, a very flat measurement of only 1.1 centimeters or 11 millimeters. It's less than 17, consistent with abnormal movement and therefore right ventricular dysfunction. I would also like to mention the use of color Doppler in tricuspid regurgitation when looking at evidence for right ventricular dysfunction. Tricuspid regurgitation develops from pressure and volume overload. As the RV enlarges, the tricuspid valve annulus stretches, and this prevents the leaflets from fully closing during systole, leading to tricuspid regurg. So using color Doppler, you can place your color Doppler box over the right atrium and look for a blue jet indicative of tricuspid regurgitation. This might be easier to visualize using the slow motion mode on your ultrasound machine. Now, in that same patient, using the slow motion, you can readily see the blue jet representing the tricuspid regurg entering the right atrium from the right ventricle. Now, there are some pitfalls when it comes to right ventricular dysfunction. You need to make sure you have the full diameter of the right ventricle on your screen. It's very easy in the apical four-chamber view to not have that RV all the way extended. And one of the ways that you can correct this is just a very small amount of a clockwise turn of your transducer, only a few millimeters, and that will open up the RV. So the size of the RV depends on probe rotation, and you want to avoid foreshortening the right ventricle. Now, just because you found an enlarged right ventricle doesn't mean that you have acute right heart strain. Remember that chronic conditions can also cause the right ventricle to dilate in size. Now, we have just discussed a lot of echo findings that are seen with right ventricular dysfunction, many of which are seen with acute RV strain that would be observed in the setting of pulmonary embolism. Enlarged RV, abnormal septal motion, the McConnell sign, tricuspid regurgitation, a dilated inferior vena cava, decreased TAPSE. There are some additional measurements that can be performed that can also help rule in pulmonary embolism, such as a decreased S prime, mid-systolic notching during your pulmonary acceleration time, a pressure gradient less than 60, a pulmonary acceleration time less than 60, what's called the 60-60 sign. So these are additional things that you can learn as your echo skills improve that will help you rule in pulmonary embolism. Now let's apply what we've learned to a clinical case. A 48-year-old female comes in with chest pain and shortness of breath. She has no past medical history. She is hypotensive, tachycardic, and dyspneic. On physical exam, you note the patient to be diaphoretic. You grab your point of care ultrasound machine. In your peristernal long axis window, you note that the RV appears enlarged in size compared to the aortic root and the left atrium. On your peristernal short axis window, again, you observed a dilated right ventricle and perhaps some flattening that's starting to take place of the interventricular septum. In the apical four-chamber window, the width of the RV appears larger compared to the width of the LV. Now, this is a real-life case. These aren't textbook images. This is what you can expect to see clinically in an unstable patient. They're not picture perfect, but I want you to see real clinical cases. In this patient, we went ahead to measure a TAPSE. The TAPSE, when measured from peak to trough, was 1.5 centimeters or 15 millimeters, less than 17. So this is considered significant right ventricular dysfunction. Let's look at another clinical case from our department. This patient presented with shortness of breath, and we noted a very large right ventricle. We see septal bowing. Look at that RV pushing in towards the LV. We decided to apply color Doppler over the tricuspid valve, and in doing so, we're going to look for a blue jet. Here's the blue jet, and this is indicative of tricuspid regurgitation. Based on the patient's clinical presentation, we were concerned for pulmonary embolism, which was confirmed with CTA. Now, sometimes you're handed the diagnosis on a silver platter. So notice very little rise and fall of the tricuspid annulus. We would expect a very flat TAPSE. There's really minimal movement. If I put my cursor on the tricuspid annulus, it really doesn't move much in an upward direction. So we have a flat tapsy, and then we look at the right atrium, and what do we observe in the right atrium? But thrombus. And this patient had a pulmonary embolism. I love it when you can actually see the clot inside the heart and nail the diagnosis. Well, I hope you've enjoyed this lecture today. It's been a pleasure speaking with you. I've got several references at the end of my lecture for you. But if you have any questions, don't hesitate to reach out to me at the email below. I hope to have the opportunity to speak with you again. Thank you so much for listening to this presentation.